elevation in which of the following enzymes is most significant in the diagnosis of this patient? A 50-year-old man is brought to the emergency department because of chest pain and shortness of breath for the last 2 hours. He describes the chest pain as squeezing in nature and radiating towards his left arm. The pain is associated with nausea and sweating. He has had similar episodes in the past, which are mostly aggravated by strenuous activities and relieved by sublingual nitroglycerin. He has had uncontrolled diabetes and hypercholesterolemia for the last 10 years. HbA1c was 8, BP is 150/90, pulse is 90, respiratory rate is 20, and temperature is 36.8. O2 saturation in the room air is 98%. ECG shows ST elevation in leads 2, 3, and AVF. All right, he's being prepared for angioplasty. Okay, what is the elevation of enzymes? Now, this question, they gave us that the data says that there was ST elevation in your lead 2, 3, and AVF, if I'm not wrong. Now, the results. So, okay, there's one more thing about these cardiac enzymes. You should better go make a table on these. They are very, very important, okay? Because each enzyme, that hours, when does it start showing up, when does it peak, and when does it come down? These 3 values for each enzyme you should know at the back of your hand, because it is not so relevant in your clinical practice, but for step 1 related, it's very important. Now, we know that your ST elevation blah 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 tells us there is a right ventricular infarction. That's ECG leads, so it's a different topic on its own. It'll take another few hours to teach you ECG. So I'm sure you'll have ECG live classes in your live MOKSH, so focus on that. ECG is very important. They'll give you ECG in step 1. Okay. Now, acute MI indicates an irreversible. MI itself is an irreversible injury. All right. What does it do? It causes necrosis of your cardiac tissue because of lack of oxygen supply. Now, this usually occurs because of, we know, the most common is your atherosclerotic plaque with thrombus that forms immediately obstruction and the complete occlusion of the coronary artery. So there's no blood. That's it. Now, reversible and irreversible can occur after a prolonged lack of blood supply. So initially it starts off with an angina, and then suddenly there'll be a fixed block causing MI. Cellular swelling and membrane damage. These are the hallmarks of reversible and irreversible injuries, respectively. Cellular swelling and swelling up. These are basics of pathology, which you guys should know if you're 50% through your step prep. Okay. And your damage, membrane damage, is definitely irreversible. The morphological hallmark of cell death is what? Pycnosis, karyoresis, and karyolysis. Granulation, fragmentation, and complete destruction of your nucleus. That's what it says. Tissue damage or necrosis results in elevated plasma enzyme levels because the cell breaks up and all your enzymes go. So every tissue damage in your body has specific enzymes that come up. So as clinicians, we try to detect those enzymes and be like, okay, this is the stage, and this is what tissue is involved. Troponin is it's like it was not there before. Myoglobin was what people used to rely, maybe like around 20 to 30 years ago or more than that. And when the troponin came up, it is one of the best indicators because it gets released faster, maybe a little late compared to myoglobin, but it stays for a longer period. So it's good as an indicator. Like, we have a lot of patients who come in at a very later stage of MI, but you can't save them. And still, if you get say it's like you're not able to diagnose its MI and you get troponin levels done, you'll know they're having a myocardial infarction, things like that. So that's why troponin I is the most sensitive and most specific marker. So like I said, its level starts to rise at 2 to 4 hours, peaks at 24, returns to normal at 7 to 10 days of post-infarction, which is pretty long. Okay. So even after a week, if they come, if troponin levels are up, and we can say, oh my God, this guy has had an MI. Okay. Right. Now, myoglobin, let's read about, okay, so this graph, before moving on, I have no idea why is it showing up. Okay, this graph is so important. You have to just edge it. Now you can see myoglobin rises fast, peaks fast, goes down fast. Your LDH is the lazy guy. L stands for lazy, L stands for late. So you can remember it like that. It peaks late, it stays for a longer duration, but it does not start early. So that's why LDH, you cannot rely on LDH. Basically, CKMB is also good, but again, it peaks off a little early and then goes away. troponin I and total CK. Now, total CK is not a specific marker, right? Many other places also CK goes up, so we're not taking it. That's it. These are the few reasons. All right. Now, why not myoglobin? It's definitely the earliest cardiac enzyme. If they have MI and are detected right the next second, myoglobins are up. They rise within 4 hours of MI, but it is a sensitive, but it lacks specificity. It's falsely observed as high in patients with even renal failure or muscle injuries. But the most common thing why we don't use myoglobin is because it comes down very fast. Like if they come after 2 to 3 days, myoglobin won't be there. Doesn't mean they don't have a heart attack, right? That's why. So somebody would answer myoglobin. This is the reason why it's not myoglobin. Okay. Now, what is this SGOT? It's a AST. It's not specific for MI. AST is also seen in different hepatic and muscle disease. And this is just mentioned here for the sake of it. Clinically, we do not use AST for MI. Okay, remember that. LDH, we just learned it rises. Look at that. It rises within 12 to 24 hours, peaks at 48, and returns to normal after 14 days of post-infarction. In fact, more than that as well. So the magnitude of the rise is directly proportional to the extent of the injury. And LDH is also present in RBCs. Thus, minor hemolysis can result in false positive result. So remember that. Okay. CKMB is useful for detecting a reinfarction in the post-MI stage. The level starts to rise 4 to 6 hours, peaks at 24, returns to normal in 72 hours. That's about CKMB. CKMB is best to detect a reinfarction. Learning object is just a summary of these, so I hope that's clear.
Thanks for watching. Please give a thumbs up and subscribe for more.